No. You guys.
Right. Okay. Good. All right, Assalamu alaikum, everybody. All right, this is my last lecture with you, but there is also the CPC this week, so hopefully we'll see you there as well. Here we're going to be, actually tomorrow, I have a lecture with you tomorrow, I apologize. So there is still the tumors lectures tomorrow, 11 to 12 as well. All right, so we're going to be talking about the prostate. We are going to look at different aspects of prostate pathology, including some of the diseases, including some of the tests that are, including some of the tests that are used, to diagnose or to follow up, actually, mostly prostatic diseases. All right, so the disorders that we will be talking about include inflammation, hyperplasia, and cancer. All right, just a little bit about actually the normal histology of the prostate. A couple of what you call a clinically important information. Now you will see that this is a prostatic gland. So the prostate is this, a glandular muscular, organ. So it's combined actually smooth muscle in addition to the glands that you see here. Now regarding the glands, a very important feature that you see in the glands is this transversely laid out basal cell layer. You need always to look for this basal cell layer and to make sure that it is present. Because if it is not there or if it is interrupted, if you are 100% sure that it is interrupted, that may actually open the door for a diagnosis of dysplasia. So the way to think about the basal cell layer, think about it the same way that you think about the basement membrane, actually. That, any neoplastic process is going to arise from the epithelium of the prostate. And then for this neoplastic process to become a carcinoma, it has to actually, an invasive carcinoma, it has to breach through the basal cell layer, the basement membrane, similar to what you see in other organs. Now, that's actually one feature. The other features that you will see in benign tissue, normal benign tissue, is going to be the fact that you have, a good maturation towards the surface, similar to what you have seen in other tissue. You will see that there are a lot of cytoplasm, as you can see here. Very important feature. Because what happens actually when the tissue becomes neoplastic or dysplastic, you will start to see that the cytoplasm will be shed out. Cytoplasm will be shed out, and the nucleus becomes the the most or the largest part of the cell. Okay, and that's why NC ratio is going to increase. If you look at the mitosis in normal tissue, you will see that the mitosis is limited to the most basal cell layer, if you will, of the epithelium. The cell layers that just actually are present above the epithelium. Okay, so you can see one right here, and you can see one right here. So the rest of the epithelium looks free. Okay. As opposed to what you see in this plastic tissue, where the mitosis will be all the way up to the most apical, layers of the epithelium. So this is a couple of caveats, that, and we will see more of it. There is also this concretions. It's simply prostatic secretions that have become, that have solidified a little bit, and will present in this kind of laminated structures known as prostatic concretions, okay, or corpora amylaceae. It does not really have any clinical significance, but when you see it, you know where you are, actually, in case there was a question about where the tissue is coming from. Now, regarding the smooth muscle, the smooth muscle is important in the fact that actually it harbors the enzyme that is going to reduce testosterone to dehydrotestosterone, DHT, the most potent androgens. Another actually important caveat, clinical caveat here, is that the prostatic epithelium secretes a specific enzyme known as PSA, prostatic specific antigen, a very important actually value for the monitoring of treatment of prostatic cancer. Now, the problem with the PSA is that it's not only increased in prostatic cancer, it can be increased in a lot of other entities. It may be increased in inflammation, it may be increased in benign, in infarction, it may be increased also in benign neoplastic process such as nodular prostatic hyperplasia, NPH. So as a result of the fact that it is not cancer specific, that is going to actually, add difficulty to using it for the diagnosis and also for the monitoring of cancer. All right, so some of the inflammatory processes that happen in the prostate, starting with acute prostatitis. This is a very common kind of presentation, 2 to 5%, but unfortunately it is the least common. You will see why it is unfortunate, in the next slide. So 2 to 5% of the overall prostatitis and caused by common pathogen. Again, what common pathogen? You will see that that's going to be actually changing with age. As the patient age, it's going to be moving from the sexual kind of bugs, like some of the STDs, into more of a GI kind of bugs, so E. coli and the rest. Now, one of the things that you will see with prostatitis is that when you treat it, you have to treat it in a very, complete way. The problem with prostatitis is that if you treated it incompletely, it's going to act as a reservoir of actually bacteria. And as a result of that, it's going to result in infection somewhere else in the GU. So someone with acute prostatitis that has not been treated will become chronic bacterial prostatitis. And that's when the prostate will be harboring actually this bacteria, but it will be, what you call falling under the radar of the patient and maybe also the physician. So that's when you start to see that the bugs will start to go to the bladder, for example, and your patient is going to have acute cystitis every like a couple of months. So as a result of that, when you treat something like prostatitis, it has to be treated very well and very completely. One of the reasons why that is difficult is because it's a muscular organ, and to actually have antibiotic to penetrate and to treat, the infection completely, that's going to, result in a longer type of treatment, longer duration of treatment, and with ample, dose for this presentation. Chronic bacterial prostatitis, that's in about, 2 to 5% of cases. Now, the most, important and the most common and the most significant is really the chronic non-bacterial prostatitis. This is when a patient is presenting to you with all actually the signs and symptoms of chronic prostatitis, but after you do a lot of workup, the only thing that you can get in the urine and also in the prostatic secretions after doing prostatic massage is inflammatory cells. So you will see white blood cells, but you will not see any pathogen. So the story behind that, it is the most common. This is actually why it is so important. It is the most common, 90 to 95% of the cases. It's a pretty, difficult diagnosis because you have to go through the motion actually of ruling out both, acute and chronic. And what's going to happen in this entity is that the patient did have an infection in the prostate at one point in time, but this turned into something that is much more complex than simply bacteria and and inflammation in the organ. So in this case, you are going to start to see that there is some types of psychiatric kind of involvement into this process. Also, there are some hormonal kind of imbalances that are going to be kicking in to result in this kind of presentation. And everything could be taken back actually to the fact that it started and was not treated, adequately, and, or was actually maltreated with the wrong antibiotic, for example, and it became eventually a chronic bacterial and then eventually chronic non-bacterial prostatitis. The patients are going to present with dysuria, urgency, and frequency of urination. Take that back, just a couple of words here because it's missing. I apologize. So chronic prostatic secretions contain numerous leukocytes in the absence of infection. All right, so you guys can fix that on your own. All right, sorry. Right. Well, every chronic inflammation was acute at one point in time. So you have chronic pancreatitis. It was an acute pancreatitis at one point in time. Nothing starts as chronic to start with. It has to go through this motion of an acute. Sometimes the acute, is what you call subclinical. So neither the patient nor the physician will be able to pinpoint it. Okay, but this is actually the process. The process is that it was acute, became chronic bacterial, and then as a result of time, really, time is going to be the most important factor here. And without treatment, without adequate treatment, it became actually the chronic non-bacterial prostatitis. We will talk about this also in the next couple of slides about chronic abacterial prostatitis and what it entails. All right, so I mentioned to you the fact that it may actually become a reservoir for the bacteria, that it may give out actually, acute cystitis, or, and that is going to definitely, entail treatment, good treatment of this condition to make sure that it does not come back. Now, one of the important things, that you will see in terms of clinical presentation is the low back pain and dysuria. Low back pain, one of the reasons why I mentioned this specifically is because you may see it also actually with, prostatic adenocarcinoma. When do you see, prostatic adenocarcinoma accompanied by low back pain? Metastatic to the bone, right? Metastatic to the vertebrae. That's when you start to see it, right? But in the rest of the symptoms, you don't see actually what you're going to be finding when it comes to, to cancer. So dysuria, perineal, and suprapubic discomfort, any kind of acute kind of presentation is going to favor actually an acute kind of process rather than a cancer, in this case, acute inflammation. If you do the DRE, you're going to be actually the digital rectal exam of those patients. You're going to be feeling, what is known as a dough-like, D-O-U-G-H. What's a dough-like in Arabic? Do you guys know? Ajini, right? Ajini. It will feel like ajina when you are touching it, and you should not be touching it. Why should you not be touching it, actually? Because one, your patient will hate you for sure because it's exquisitely painful. This is one. And two, actually, the fact that this may release some bacteria into the blood, and, you don't want to do that. I think the least, the patient and the physicians actually touch anything, the better that it is. All right, so where does that come from to start with? Again, that's something that is going to be actually going with the age. So you will see that young people, STDs are going to be there in the form of gonococcus and then chlamydia and staph. Now, with actually older age, you will start to see that E. coli is going to become the most common pathogen in later years. All right, so chronic pelvis pain syndrome. So I may not mention to you. So it has two names: chronic non-bacterial prostatitis, also known as a chronic pelvis pain syndrome. So you no longer actually have an inflammatory condition. You have a constellation of symptoms that the patient is presenting with. All right, so how would you, in the US, they take it pretty seriously. And, to diagnose it, you need to complete an NIH, National Institute of Health Symptom Index. That's surveyed by the patient and also by the physician, and from the tests that you have done on the patient. The most important ones are going to be actually the objective findings. So stuff that the physician will be finding. including the findings on the digital rectal exam, including the findings of urinalysis, the findings of the PSA. You know, after you do prostatic massage, you're going to be collecting this fluid and sending them, you know, for stain and gram stain and culture. And the least are going to be the symptoms reported by the patient. You see that again in many different entities. Where else have you guys seen it actually? You know, when it comes to using the a criteria for diagnosis. Fibromyalgia is one. Again, so objective versus subjective. The objective, you know, are going to be actually far more, you know, stronger, you know, when it comes to diagnosis than this. We saw it in a lot of other diseases actually in the MSI block, right? So rheumatoid arthritis was there, and used to use it also for SLE. The reason for this is that those diseases are pretty complex diseases, and there is overlap with other entities. So you need to use everything at your disposal. All right, so so what's going to, you know, happen as a result of compiling of this, you know, survey, if you will, is going to document the prostatic inflammation in the absence of infection and the list of symptoms your patient is coming in with. So what is the underlying etiology of this process? The underlying etiology is that an interplay between psychological factors as a result of the fact that this is a chronic process, and dysfunction of the immune, neurological, and hormonal systems. Okay. So some of the theories that are behind the disease, including exhausted hypothalamic pituitary adrenal axis dysfunction, and adrenocortical hormone abnormalities, and neurogenic inflammation. You know, some of the theories that have been put forth to explain, you know, why this happened in the prostate. Right. So one of the things that, you know, you need to keep in mind is that prostatic biopsy for an inflammation is not really indicated unless it is actually, or there is a high index of suspicion that it is a granulomatous inflammation. Granulomatous inflammation in the prostate could be due to TB, but that's very rare. You know, it's probably more common to be in the kidney than to be in the prostate, because again, the prostate, you know, is a pretty tough organ to penetrate, even for bacteria. So that's very unlikely to happen, but you keep it in the, you know, very back of your mind. However, actually, a much more common entity will be the using of BCG. What's BCG? Do you guys know what BCG is? For TB. It used to be done as a vaccine for TB, right? Is it still being used? No, it's not. So that used to be done actually in very past years. It became actually prominent during the COVID-19 era, if you will. Why was it or why did it become important actually, at least not very important, but important to look at in the COVID-19 era? Because they looked, you know, from the epidemiological study, they found out that countries that actually received the BCG vaccination or inoculation had lower rates of COVID-19 infections and had less, you know, mortality from COVID-19 infections when it happened, as opposed to countries that either never received BCG, including the US, or actually received it, but, you know, stopped receiving the BCG, you know, early on in the past century. Now, BCG has another indication. So we're not talking about here BCG in the form of an inoculation, but rather actually as in the form of a treatment for a neoplasm known as urothelial cancer. So with urothelial cancers, or what used to be called transitional cell carcinomas of the urinary bladder, BCG is used actually to elicit an immune response, immune destructive response in the tumor cells. So when you instill BCG in the urinary bladder of someone who have urothelial cancer, the BCG is going to result in a granulomatous inflammation or granulomatous reaction in the urinary bladder that is going to destroy, believe it or not, the tumor cells. In the process of doing so, this process may extend into the prostate. And that's when you actually have, you know, the patient may be having granulomatous inflammation. So if there is any kind of, you know, suspicion that this may be the case, you will be actually biopsying the prostate. Here is an example of, of what a prostate will look like when it has acute prostatitis in an autopsy. Okay, but the autopsy was done for different reasons, because acute prostatitis should not be killing the patient. Now you see this greenish, yellowish or whitish, what do you call it? There is a word for it, not blue, goo, G-O-O. What is that? Pus, exactly, that's pus. Very good. So right there, you have made your diagnosis right there on the on the gross pathology. Okay, now we are going to be talking about nodular prostatic hyperplasia, the big elephant in the room, so to speak. For many reasons, it's a very common condition. If man lives long enough to be in his 90s, 95% of men are going to be having actually NPH, okay? So it's, the most important risk factor when it comes to NPH is age, actually. It's nothing else except age. There are other risk factors, but age is right there at the top. And if you survey people, survey men in their 40s, you will start to see that this does have actually, a good number of patients with the condition. All right, so rises exponentially with age, and here you see, proliferation of stromal and epithelial cell units. All right, so what's the pathogenesis? It's an androgen-dependent process. Androgen-dependent process. And that has been actually confirmed by a couple of, of course, from a lot of studies, but mainly actually from, the fact that males, when they are castrated before the age of puberty, they will never, go on to develop nodular prostatic hyperplasia. Also, males with genetic disease that block androgen activity, what you call androgen insensitivity, also never, go on to develop nodular prostatic hyperplasia. Most of the action is due to the dihydrotestosterone action on the prostate, and we have talked about actually which cells provide actually the enzyme for that, and those are the smooth cells. But the process itself is a combination of both smooth cell hyperplasia and also glandular cell hyperplasia. Of course, benign, both for both smooth muscle and the glands. Now, if you actually see one of the pictures, we'll talk about the pictures in a second. How does it present? So in terms of presentation, even though it's a huge problem, but only 10% of men with pathological evidence of nodular prostatic hyperplasia have a clinical manifestation. So you're really talking about a minority of the people with this condition who present with this, with the symptoms and signs of nodular prostatic hyperplasia. Now, it is most commonly going to happen in the periurethral region of the prostate. So as a result of that, most of its symptoms is going to be related to the, the urinary stream. What does it do to the urinary stream? So the symptoms, of patients, presenting with nodular prostatic hyperplasia will start with someone who's unable to initiate, urination. And the reason for this is that, this muscular process, if you will, mostly muscular and also glandular process surrounding the urethra is obstructing the flow of urine. So difficulty, or what you call hesitancy. Now, once the patient urinate, you will start to see that the urinary stream is weak. This is one. So you will start to see dribbling, as a result, again, of the pressure that is applied to the prostatic urethra. And then there will be actually incomplete emptying of the urinary bladder, because most of the urine has passed, and now the rest of the urine does not have the volume to maintain the continuity of the urinary stream. So as a result of the fact that you have a residual volume of urine in the urinary bladder, there will be increased frequency of urination. Now, if you look at the prostate that is affected with NPH, you will see that it is formed by many nodules, large and small nodules. And the prostate in general is enlarged. The prostate normally is about 3.2 2 to 1.9 or 1.8 centimeter to about 1.8 centimeter, 3-dimension actually width, width, thickness, and length. When it becomes affected with MPH, it actually takes the shape or the size of a medium-sized apple, actually huge. And I remember, the ones I used to receive tons of them, when I used to gross actually all those prostate. All right, now what's going to happen, the fact that it is mostly limited to the transitional zone of the prostate, you would see that the urethra, the prostatic urethra, is compressed to a slit-like lumen. That's what I meant by a slit-like lumen. And that's when you see all these nodules. Okay. All these nodules are actually what make up the prostatic nodular hyperplasia, limited to the periurethral or the transitional cell region. Now, as a result of the fact that you have this, growth in the prostate, the bladder itself will be working overtime to overcome actually this compression. And in the process of doing so, the bladder muscular fibers will hypertrophy, resulting in what is known as, what do you call those? Trabeculations, exactly. Trabeculation. Now, this is probably what you call a mild kind of trabeculation. But in this mild trabeculation that has been ongoing, you see this actually structure right here. What is that? A stone. So a stone actually that that resulted from the stasis of urine. So what happens as a result of the blockade or the incomplete blockade of the prostatic urethra? So infection may actually happen. Stone formation may happen, all right, and acute cystitis may happen, so in the form of an infection as a result of the fact that the patient will always have residual volume in the urinary bladder. And finally, actually, cancer, there is some association with cancer, especially because it may predispose to chronic inflammation. This is actually the most severe form of the trabeculation that I have shown you before. And you see here, the fact that the muscular layers, the 3 muscular layers of the urinary bladder are not completely overlapped. So there are defects actually among them or between them. Through these defects, the diverticula may happen, acquired diverticula in the form of herniation of only the epithelium and the lamina propria through these defects. Now, if you go back to this, what do you do actually to take care of that? In this case, medicine provided actually a direct solution, if you will. So you will come inside and you're going to start to scrape this region, scrape. The tool that you use actually to scrape is similar to what you do. You guys won't know it because none of you cook, which is good. Do you know how to do eggplants or zucchini? Stuffed eggplants or zucchini. Do you know how to do it? I'm seeing the boys are saying yes, but the girls are. That's quite a telling of our times, All right. So what do you do? What do you use? What is that tool? We have a name for it in Syria, but it's a horrible name, really. What do you call it? Huh? Chorus? I don't know. I'm not going to say it because then you will remember me for saying that. I will leave that to your imagination. It's simply it's a hollow, partially hollow, like tool, right? Half a hollow tool. You put it in and you start to scrape, right? Now imagine what do you think this process is going to result in the prostate? When you start to do this process in the prostate, it's a very bloody process. Very bloody and a very exquisitely painful process, but it's going to actually do the job. Why? Because it will be releasing, it's going to go after the pathology right away, right? The central region of the prostate, take out as much of that as possible, resulting in all these actually pieces. Now, so it was a nightmare for the surgeon and for the patient. Now it's a nightmare for the pathologist, believe it or not. Why? Because the pathologist has to weigh and has to describe all those sections and has to look very carefully, under the microscope. Why do you think they have to look? We're saying it's benign. I told you it is in the right place. And, it's going to probably be actually absolutely benign. Why do you think they will have to look very carefully at these fragments of the TURP, transurethral resection of the prostate? Check for malignancy, but why? What is the association? I'm telling you, it's benign. Okay, very good. So from the terms from the point of view of pathophysiology, both cases, actually, both conditions, the nodular prostatic hyperplasia and the prostatic adenocarcinoma are both actually dependent on androgens. So there is a lot of overlap. How about the age? Is it the right age? Absolutely, because prostatic adenocarcinoma also happens with advancing age. So you will see that, if you look at a graph, for example, showing you the incidence of prostatic adenocarcinoma and nodular prostatic hyperplasia, both of them are going to follow each other, right? They are going to be mirror image of each other, okay? Probably not as much prostatic adenocarcinoma as cases of nodular prostatic hyperplasia, but definitely you will see that there is what you call a shadow effect. They are going to follow each other. They're gonna be intertwined with each other, if you will. But there is another reason for actually why you need to look at margin. Unfortunately, with this one, there is no margin. You're really doing it haphazardly. You're trying to scrape as much as possible. You don't worry about the margin here. When you take a resection and the margin that you will look at when it comes to prostate are going to be the capsular margin, the capsule that surrounds the prostate, because there is one entity known as extracapsular extension, a very important thing actually to notice if you actually look at the prostatic adenocarcinoma. The reason for this, because it will take the stage of the tumor up. But here stage is not really the reason. Further.
Could be possible lamination?
No. Say it again. Who's speaking? Actually, I cannot see. What did you say? Angiogenesis. Also no.
Maybe like the process of nodular hyperplasia could mask it, like an independent process.
It's always you will see that there are a lot of correlation actually between the two conditions. The reason why actually you need to look at each one of those is that the majority of cases, believe it or not, of prostatic adenocarcinomas are incidental findings. Could you believe that? Incidental findings. So it can be there really without the patient having any idea that it is there. And that's the reason why actually they say that prostatic adenocarcinoma is a cancer that most of the patients die with than die from. So it's not a cause of death. It is mostly an incidental finding. So as a result of that, when you receive this much, and you can imagine that this will be really a black day for the pathologist, they have to go through hundreds of slides, because each one of those, is going to be, you take one section per 1 centimeter. So this probably, from this case, you will probably have at least 30, 40, sections. That's a lot of sections. If you actually multiply that with the number of patients who do the procedures on a daily basis in your OR, you'll realize what I mean in terms of, a lot of work for everybody in the lab. All right, so now when you take a section of this and you send it, and if it's only a nodular prostatic hyperplasia, you're going to be seeing actually large glands that are, set in the form of nodules, as you can see here. These are the nodules that we were looking at when you actually were looking at the growth of the nodular prostatic hyperplasia. So you will see also that these are large glands. Large glands in the prostate is a good thing, or are a good thing, because very rarely there is only one variant of prostatic adenocarcinoma that has large glands. The majority of variants of prostatic adenocarcinoma are small glands. When you start to see small glands, that's what you need, where you need really to worry in the prostate. That's when you immediately will go in higher power and start to figure out if what you actually what you're having is a prostatic adenocarcinoma. So right there, from a single look, of course, when your license is going to be based on picking a diagnosis of cancer. And the beauty about actually pathology is that once you take a section, from a patient of pathology, this section will stay forever in the lab. So 10 years down the road, let's say your patient, you said that this is a nodular prostatic hyperplasia, that there is no tumor. 3 or 4 years down the road, your patient developed prostatic adenocarcinoma. They go back to the earlier biopsy and they look at it very carefully. God forbid they found actually a prostatic adenocarcinoma in it, because you're going to be losing your, you have, in the US, what is known as 3 strikes and you're out. Are you guys familiar with it? 3 strikes and you're out, similar to what you see in convicted felons, actually. So 3 strikes and you're out. You are sued 3 times, you lose 3 times, they will take away your license. And of course, when they take away your license, they don't just take away your license. They take away all your toys, so all the cars, all the planes, sometimes the trophy wives or the trophy husbands, for that matter. This is a joke. And your kids as well. Your kids will leave you, regardless of what you do. So at the end of the day, you're going to be losing everything. So be very careful. This is why, you see pathologists at the end of the day, like their eyes are the size of, big apples, really, because they have looked so, dearly and so carefully at this. Thank God now there is something known as AI, process that is really AI image analysis process that is going to be of a great help for pathologists. Of course, pathologists have actually fought this process tooth and nail, because they feel it will take away, jobs or business from them. Not so much, but it will be a great help to make sure that they do not miss out on, really, how could you not be sure that one of these glands is a cancer gland? So this is why, you need to be very careful and really, make sure that you cover all your bases when you look at the sections you're looking at. Now, the other thing that is going to tell you that this is benign, you look at these cells, do they look to you like they are angry cells? They don't. They are happy cells. Happy cells have a lot of cytoplasm. Why is that the case? Because once you have a lot of cytoplasm, what happened to the NC ratio? It's very small, right? NC ratio, nuclear cytoplasmic ratio, cytoplasm a lot. That's going to take this ratio to a very small, value, and that's very good, because NC ratio that is low is benign. That's a benign cell. So this is 1. 2, if you look also, there is a good maturation. You no longer really see much cells or much nuclei at the most upper cell layers, mostly cytoplasm. Again, that's another very important, feature right here. Now, if you look also, you don't see any kind of piling up of cells. Once you start to see cells that are piling up on top of each other, that's something that, you need to investigate. You go on higher power and you start to look at, the features of those nuclei. Are they dysplastic features? Do they have, this prominent nucleoli that the prostatic adenocarcinoma has, or are they actually without nucleoli? Do they have jagged nuclear edges? Do they have hyperchromatism? All of these are features that you need to investigate if you start to actually suspect that there is one region within these glands that are going to be malignant. And then, the star of the day, the star of the action is going to be the presence of this basal cell layer. If you have any doubt about the presence of this basal cell layer, there is actually a cytokeratin stain. Cytokeratin stain, a low molecular cytokeratin stain that is going to highlight the basal cell layer for you. Okay. Now that's an indirect way of saying there is no tumor. Why? Because you have stained actually the basal cell layer and you see that it is present. Now the problem becomes actually when you start to see that there is an incomplete basal cell layer. So in this case, you are going to call your histologist and tell him, take deeper sections of the prostate. These deeper sections may actually start to allow the basal cell layer, that part of the of the gland. Because imagine, what does this gland look in normal in normal life, in normal live prostate? What is the gland a representative of? Is it a flat sheet? What is it then? Tubular ball, right? You're taking a section and you're actually carving it through this ball, right? So at one point in time, maybe your section did not really go through one part of this ball that is going to be represented with this circle. And you look at the basal cell layer and it will look absent. That's when you start to take deeper section. This is the first thing that pathologists will do, deeper sections of this, of this tissue that you're looking at. And then you will start to see, for example, that the basal cell layer started to appear again. That's a very, if you think about it, that was the only thing really we had for almost 90 years in prostatic pathology until molecular pathology came to the rescue, of course. I always you can see that I always, a big proponent of molecular pathology because it is my specialty after all. Okay, so it actually now, brought to the forefront a immunohistochemical stain known as Amalcar, that is going to stain the tumor cells themselves. And that is going to be very important because you're no longer actually doing diagnosis of a very important cancer, the old way. You're not doing it indirectly, you're doing it directly, because that stain is going to stain the prostatic cell for you. Now, unfortunately, there is nothing in life that is complete. So you will see that it will stain, let's say, I don't really know the number, but I know from my experience in research, you will see that it will stain 80% of the cases. So the question will be, what do you do with the other 20% of the cases? That's when the eye of the pathologist and the low molecular cytokeratin stain, and also the Amalcar, that will come to the forefront to rule out or rule in the presence of prostatic adenocarcinoma. All right, so where does prostatic adenocarcinoma? So we're done now with nodular prostatic hyperplasia. So the problem with nodular prostatic hyperplasia is that it mirrors actually everything that happens in prostatic adenocarcinoma. Both of them are androgen dependent. Both of them are going to increase with age. Again, the most important risk factor for prostatic adenocarcinoma, number one is age. Number two is what?
Smoking.
Not smoking. No, thank God, smoking is, I keep telling that myself. It's not smoking. What is it?
Face?
Well, if someone is receiving androgen, but people don't really do that, right? They don't do this a lot.
Saturated fat?
Diet, absolutely, diet. Prostatic adenocarcinoma is one of a couple of tumors that are definitely so much linked to the diet. What other tumors are linked to the diet? Cancers linked to the diet? Colon cancer, pancreatic cancer, absolutely. Gastric cancer, esophageal cancer. What else? One second, I missed one. Breast cancer, did I mention breast cancer to you? Yes, breast cancer as well. And also endometrial cancer. Okay. All right. So diet is there as well. So, you see that they are going to mirror each other, the NPH and the prostatic adenocarcinoma. Now, one thing they differ is where they arise from. You can see actually with nodular prostatic hyperplasia that it is a process that is going to be focusing on the transitional zone, whereas the prostatic adenocarcinoma will arise in the usually posterior aspect of the prostate. Okay, as you can see here. Nodular is benign, nodular prostatic hyperplasia. Right. So now the DRA, digital rectal exam. We have seen with acute prostatitis that it is dough-like. When it comes to MPH, it's going to look rubbery, feel rubbery. So firm but rubbery. What do you think is going to happen with prostatic adenocarcinoma, especially when it is from the peripheral posterior, aspect of the prostate? It's going to be indurated, what you call hard or indurated feeling. Very hard, very fixed, if you will. All right, so incidence, again, you're going to be seeing that age is really a very prominent risk factor. So a large number of autopsy patients, and this happens at least in two autopsies that I've done, you actually see this, you see the prostatic adenocarcinoma without really knowing anything in the history, without the patient ever complaining about the prostate. Again, a cancer to die with than to die from. Remember that? Like all disasters, it is most commonly happening in actually minorities. So blacks, and Arabs and Hispanics. This is actually usually the white race is a protective factor, pretty much across the board, except what we have talked about in the prior, lecture. Lower incidence among Asians, also Asians do well, they pretty much do well, when it comes to many things. So what is the pathogenesis of prostatic adenocarcinoma? Androgen should be at the top of the list, but also diet, actually. diet. How does diet actually affect cancer risk? In one word. Like bad diet. Thank you very much. You know, this is something I'm gonna put on my desk and take a picture. You know, take a picture of it wherever I go. Very good. Bad. It's absolutely bad diet. But how does a bad diet? Okay, thank you. You know, cause actually cancer or contribute to cancer? How does it do that? No. Let's see. Did any one of you do any cancer research?
Yeah.
Anybody? Nobody in the whole class. MashaAllah. Huh? One word. Mutilation. Mutilation. Remember that. You won't hear it anywhere else. This is my actually what you call it, my pit for my lecture. You know, you won't hear it anything else. Mutilation is definitely the way that, especially diet, affect cancer risk. Hypermutilation or hypomutilation does not really matter. That's going to actually suppress or overexpress certain genes that will play a role in cancer. And this is no exception, as we will see here. All right, so acquired somatic mutations have roles to play in the pathogenesis of prostatic adenocarcinoma. So androgen, central role. How about that? Again, castrated men. It's pretty good, actually. Castrated men before puberty do not develop prostatic adenocarcinoma. Dependence on androgen. One of the things that you do when someone has prostatic adenocarcinoma is take out, unfortunately, the testes. Why? Because when you do that, this tumor, what happened to those tumors? They regress. You know, the tumor regress and disappear actually because of the fact that it is androgen dependent, you know, tumor. Of course, you don't take them out actually surgically, but you call experimental surgery to remove the testes, God forbid. You do it in a much more actually civilized way, which is what? Chemical castration, right? And you give the androgen the best hormone that is going to counter it, which is what counters, you know, masculinity to the extreme in life? Estrogen, the best hormone in the world, actually. You know, so you give the hormone estrogen, and that's going to take care of business. That's going to put actually the, you know, testosterone production to rest. All right, so now, you know, some will say, well, some came actually, as you know, science is always give and take. A group of scientists came and said that there is a subset of tumors, you know, that are resistant to anti-androgen therapy. And by saying this, they were saying that actually it's not really, you know, the full story that these tumors are androgen dependent. Well, it turned out that actually those groups of tumor, those groups of men who have these tumors, you know, have the receptors of the androgen mutated. As you know, there are 2 types or 3 types of mutation. What are the types of mutation? You know, when a gene is mutated, what happens to that gene? Either it will go into what you call an activating mutation, right? And as a result of that, you will see a signal that actually keep firing into the nucleus, right? Or it's going to be inactivating mutation, right? You know, that is going to put this gene to rest, or it's going to result in no change whatsoever, okay? So in this case, they found out that those actually mutate, that the receptors of the androgens on the surface of the cells are actually experiencing activating mutations. And those activating mutations are sending signals to the nucleus to put the cell in a stage of a hyperdrive. You have seen that before in the POD. What was that? Similar to what you find here. What was the name of the gene that actually was put into a hyperdrive, you know, as a result of a mutation, either in its GTP binding site or if the which one? No. RAS. Who said RAS? Excellent. The RAS gene, absolutely. If you recall the mutation in the GTP binding site that is going to make actually the GTP binding to its pocket permanent, and as a result of that, the cell, the gene, the RAS gene, is going to be, activated, you know, permanently and keep firing into the nucleus, resulting actually in, you know, resulting in putting the cell into a hyperdrive of cell division. So at the end of the day, the whole story is that androgens play a central role in 2 things. One, in the formation of the tumor, in the development of prostatic cancer, and 2, in the maintenance of these tumors. All right, heredity, increased risk among first-degree relatives of patients with prostatic cancer. And the GWAS, the genome-wide association studies, showed that MYC is actually is mutated in African American patients, and that a locus on chromosome 1 was the culprit for white population. Environment, migration studies. What migration studies? The Japanese migration studies. This is an old study that actually have followed patients from Japan who moved to the US before they were actually put in camps in World War II. They followed them, and actually they looked at the incidence of a prostatic adenocarcinoma in those patients. And they found out actually that the prostatic adenocarcinoma incidence of the immigrant Japanese population in the US was much higher than that of the motherland of Japan, but was less than actually the ones of the new homeland, the US. And the reason for this is that actually, what do you think the reason for this? Let's say. Absolutely, diet. So you can tell actually that the American diet was really very poor. Was a very poor diet, long time ago. It's not really anything that came to the forefront now. All right, here's acquired somatic mutation known as the TMPRSS2. What is, let's see how much you guys are following new news, especially with the COVID-19. What is the TMPRSS2 used for? That actually gene. Don't look at the E2S. This is a fusion gene. The TMPRSS2. Where actually is it important? Have you guys done any reading about COVID-19? That's one of the receptors used by actually the virus to gain entry into the cells, by the the COVID-19 virus to gain entry into the cell. In this case, this is a separate story here. TMPRSS2 E2S, a fusion gene. What do you think? Just out of your experience from the POD, what will the fusion gene do actually in this case? So render the cell oncogenic by actually putting the cell in a hyperdrive and inhibited proliferation of prostatic epithelial cells. But that's not really the start of the process, even though it is at 40 to 70% finding in prostatic adenocarcinoma. The start of the process is right here. The hypermethylation of the GTSP1 gene. We'll find out what it does in a second. That is found in 90% of primary prostatic adenocarcinoma, a very important gene to remember. Again, methylation. So this is the most likely link to diet. Okay, so how diet does it? Diet is going to do it because this fat, this good stuff that comes in the, like high fat, low protein, high sugar diet that pretty much I think everybody loves, is going to render its effect, exert its effect on this gene, okay, and is going to hypermethylate this gene. Now, what does hypermethylation do? What could hypermethylation do? Is it up the expression or is it knock down the expression? Either way, it can go either way, right? It can go either way. In this case, actually, it is going to be up-regulating the expression. As a result of its up-regulating, the expression is going to modulate the signaling pathway favoring neoplastic transformation. This is one. Two, it will also actually knock down. So the same up-regulated GTSP1 gene is going actually to favor neoplastic proliferation, but at the same time, it's going to knock down the formation and the production of the antioxidant proteins and the detoxification enzymes. All right, two opposite actions on two opposite pathways. All right, so most of the time actually is going to be in the peripheral, in the peripheral aspect, peripheral posterior aspect of the gland. As a result of that, when you do the digital rectal exam, it will give you this, indurated feeling, this hard feeling of the prostate. Now, the majority of the prostatic adenocarcinoma are small, asymptomatic, and incidental findings that are found out on a needle biopsy of the prostate for the workup of prostatic specific antigen. Actually, that opens a Pandora box really, because a lot of labs in the States do not really resort to doing the PSA value. We'll find out why in a second. You guys have actually break now, right? And you want to finish, I'm sure, Give me just 5 minutes and we'll be done. All right, so we'll find out what that means in a second. So unlikely, because of the fact it is in the posterior aspect, it will not cause urethral obstruction. When will it cause urethral obstruction? If it has spread, right? If it's spread from its common location to the rest of the prostate, engulfing the the transitional zone, correct? If it's posterior, if it's actually still small and has not really spread throughout the prostate, then you will find out that it will not cause any kind of symptoms related to urethral obstruction. But if it has spread outside actually that region, engulfing the rest of the prostate, that's when you will find out, that's when the patient is going to present with, again, urethral obstruction symptoms similar to what you find in nodular prostatic hyperplasia. All right, so the tumor grows peripherally through the capsule and it may invade the seminal vesicle and the neck of the bladder. Spread is classically through perineural space. We will we'll have a nice picture about this. Metastasis is both lymphatic and hematogenous. The hematogenous one is going to result in the bone-producing osteoblastic metastasis. Now, the PSA, this is something that we are going to talk about. So the PSA is a production, the prostate-specific antigen is a production of the prostatic epithelium. If you have NPH, what do you expect actually to the PSA value to be? Increased, right? If the patient, because you have much more of the prostatic tissue, much more of the PSA will be used. If you have infarct of the prostate, the same exact thing, the PSA may increase as well. If the patient has inflammation of the prostate, the same exact thing, the PSA value is going to increase, okay? If you have, I did mention the NPH for you. So all of these are actually what you call non-cancerous causes of the elevation of the PSA. So you need to make sure actually when you are examining your patient that he does not have one of those conditions, because this may account for the PSA level. As I mentioned to you, the size of the prostate is going to increase with age. This is why at 90, you will have 90% of the patients having actually nodular prostatic hyperplasia, but at 40, you will have 40% of those people. So what happened to the PSA level as a result of age? Also increase, right? So it's going to increase. So if someone comes to you and he is already 55 and you do a PSA level and you find out that the PSA level actually is let's say a 4 nanogram per deciliter. The question is, what value does it give you? If you have not done a basal level of the PSA, a level that you have done when the PSA value started to become meaningful, that is around the turning of 40 years of age. If you don't have a basal level, that the value of the PSA testing later on in life is going to be diminished. So as a result of that, one of the reasons why a lot of labs do not really do the PSA, at all, because if you do the PSA and you find out that the PSA value is high, what is the next step? You have to biopsy the patient. Okay, the biopsying of the patient is a pretty complex, process, because the patient has to be, on general anesthesia. The operating table is going to be working. A surgeon, a neurosurgeon is going to be there. So you're going to be actually creating a lot of. And then at the end of the day, it may be simply a small tumor that minds its own business. How about this? There is a policy in the US, it used to be called don't ask, don't tell. So in this case, probably this is what the hope was really, even though you will never find it written in any book, but I can tell it to you, is that you don't really do it unless, the patient comes in and, the patient is already 60. There is definitely some signs and symptoms, that is going to tell you there is a prostate problem. And when that happens, you do the PSA value and you follow up the patient. This is why actually you see that it is mostly important in monitoring treatment, because the PSA is secreted by the prostatic epithelium. So if you take out the prostatic epithelium, you do prostatectomy for prostate cancer, what will happen to the level of the PSA? It will drop to 0, right? That's actually, it should not be, there should be no, no PSA whatsoever. If you start to see that there is a PSA, what does that mean? That there is actually some kind of metastasis somewhere that you have missed, or there is actually a left out tumor, right, that you are not able to take out completely. So you need to do more actually work to make sure, you know, that this is the case. Now, what happens if you take it out, went back to zero, then a year later, you looked at the PSA again, and it already rose. Metastasis has happened, right? Metastases that were in the blood in the form of cells now are actually, they have established themselves somewhere else, and they started to actually make more PSA. So another actually, you know, use for it is the most important use for it is going to be monitoring treatment. Now, that's why actually you see it's also useful in diagnosis, but the jury is out because the most places really do not favor doing it, especially for a young age patient, for the reasons that I mentioned to you. But there are other reasons as well. For example, you know, does the prostate of someone who is, you know, who is considered to be of an average size, the same like someone who is considered to be of a smaller size, like a smaller size man, you know, versus average size man versus actually, you know, a larger size man? The answer to that is also no, because the size is going to be affected. The size of the prostate will be affected, and the value of the prostate will be affected as well. So you need to look at weight. That is going to actually be that is going to be, you know, factored in, if you will. Now, how about race? Is that going to be the same? A black man versus a white man versus a Hispanic man versus an Arab man? Again, there is difference. So one value, you know, like one size does not fit all here. That's why actually they started making what is known as sliding scales that accounted for age, accounted for race, accounted for weight. And they introduced these sliding scales to the use of the PSA to make the use of the PSA meaningful, okay? And also they introduced, you know, the serial, you know, testing. So one value in time for the PSA will have, you know, much smaller significance than if you have a series of PSA testing. If you do actually the PSA test today and the PSA test of the same patient in a year from now, and you see that the PSA value has increased by 1 point from this point to the next year's point, and even though the value of the PSA is still within normal limits, is still less than 4, your patient has cancer in 90% of the time, because it is the series that you will look at, the crescendo that you are looking at, rather than a testing in a 1 point in time. All right, so 4, less than 4 is cutoff of normal. But again, that's a lot of criteria that you are going to apply, because someone who is 1 today, 1 nanogram per milliliter today, a year from now is 2, has cancer. How about that? They are still less than 4, but they have increased significantly enough. And the only way that this increase is going to be actually mirroring cancer, you know, is going to happen if there is a cancer that is behind it. Okay. Now, 4 to 10 is what you call a shady, you know, shady kind of value. That's when you will introduce the criteria that I will mention to you, you know, now. So what you call limitations, before that, limitations, non-cancer specific, it may actually arise in a lot of other conditions. How about this? 30% of prostatic cancer are going to be within normal limit, and they are still bound by the prostate. They did not go anywhere. Another thing actually is that the equivalent of a cancer in situ, known as high-grade thin prostatic intraepithelial neoplasia, does not increase the PSA value. So what are the refinements that were introduced, the criteria that were introduced to the PSA value to make it more meaningful? One is the velocity, you know, the velocity of the PSA velocity. That's the increase within 1 year, something to keep in mind. 2, the sliding scale to look at the MPH with age, to look at the MPH contribution to the PSA value with age. So sliding scales. Of course, there is also sliding scale for race that they use, sliding scale for size that they use as well. Finally, looking at the free PSA value. So it's not really the total value of the PSA that you need to be concerned about. Rather, actually, it is the free PSA value. Where is the rest of the PSA if it's not the free PSA? Bound to protein in general, right? Protein. All right, so PSA, this is the work of it. The most important aspect of it is that it's valuable in monitoring response to therapy and the serial measurements that we have talked about. We talked about rising PSA level after treatment and what does it mean. Here is a cancer of the prostate. Every time you see yellow color, that's actually going to be, suspicious for a prostatic adenocarcinoma. This is the normal prostate that we have talked about. This is a high-grade pin. So what's a high-grade pin? You can see that most of the cytoplasm has been shed out, correct? Not really much cytoplasm. The nuclei, on the other hand, have increased in size. The nuclear borders have become irregular. A lot of them have nucleoli. The nucleoli of prostatic adenocarcinoma is a very peculiar one, a pretty large one, larger than 2 micron. Okay, most of them have actually this. There is no maturation toward the surface. And you look at the basal cell layer, and the basal cell layer is missing actually. Okay, either missing completely in high-grade pin or interrupted, meaning you won't be finding it in most of the tissue that you're looking at, but you may find it in the rest of it. Here's another high-grade pin. Now, not only high-grade pin, so what is this? Why are these cells on top of each other? This is what you call stratification. This always is a worrisome sign when you are examining prostate, prostate samples, prostate biopsies. When you start to see the piling up of these nuclei all the way toward the surface with absolutely no maturation, you know that there is something happening here. If you take a section, this section is really lucky. Why? Because it was able to find out the breach of the basal cell layer. And now the invasion, now the high-grade pin is no longer high-grade pin, but prostatic adenocarcinoma, because now it is in the stroma. The cat is out of the hat. These malignant glands have invaded the stroma, and now they are frank prostatic adenocarcinoma. Here is actually just the prostatic adenocarcinoma, the garden variety type. You see these are smaller glands, and you can see that they are one cell layer. That is only the epithelial layer. Whereas the basal cell layer, it's completely gone. You don't see it anywhere else. You look at the NC ratio, it's pretty high. And you look at the nuclei, and they are also very large nuclei. I'm sorry, the nucleoli. The nucleoli are very large nucleoli. The majority of these cells have these large nucleoli. A very, characteristic finding, I would not say specific, but characteristic finding for prostatic adenocarcinoma sections. A very, common way of the spread of prostatic adenocarcinoma, not specific because you see it in other tumors, other glandular tumors, is what is known as the Indian filing pattern. Indian filing, this is what used to happen in World War I. When India was with the British Empire, that's when actually the file of Indian soldiers, which is one line, is going to invade, similar to what you find here. So one file of malignant cells are invading actually the stroma. Indian filing, you see it in other glandular tumors such as breast and pancreas and others as well. Now, it is a rich, tumor with PSA. So if you actually throw this PSA on a biopsy that you have, it will be highlighted. That's a very important test, especially when you have, a suspicion that it is a prostate carcinoma that has invaded the bladder, okay? Or is it a urothelial carcinoma that has invaded the prostate? A PSA positivity is going to rule in prostatic adenocarcinoma for you and rule out, urothelial cancer. Here is actually the perineural invasion. So you can see, that this poor nerve now has been encapsulated with these tumor cells. So this is a sheath of the nerve, okay? And within the sheath of the nerve, you see all these tumor cells. What do you expect this patient is experiencing now? One horrible kind of pain, right? Cancer pain is never really a simple thing. It's the most severe form of pain, the most intractable form of pain, to which medicine has not really, unfortunately, found any kind of answer. Now you see actually this kind of findings in the vertebrae of this patient. What are these? Osteoblastic metastasis. What do you expect to find in the blood of this patient, in the serum of this patient? Increased alkaline phosphatase, absolutely. All right, so summary: acid phosphatase, when spread outside the capsule, you will see. So now you have ALK phos when you have osteoblastic metastasis. When the prostate adenocarcinoma has gone out of the capsule, the acid phosphatase has increased as well. Don't ask me why. That's why they listed it. There is no reason really why it is the case. If you find out, let me know. So PSA value above 4 abnormal, above 10 mostly cancer, 4 to 10 shady, when you need to apply the criteria that we talked about: PSA velocity, PSA density, sliding scales, serial testing, and free PSA. Thank you very much.